Hi everyone and welcome. I'm Shilpa Venkatachalam, Chief Patient-Centered Research Operations and Ethical Oversight Officer at the Global Healthy Living Foundation. Thank you so much for joining us today on this webinar titled Navigating PMR or Polymyalgia Rheumatica, Expert Guidance and Real-World Experiences with PMR. This webinar is part of our CDC-supported work focused on improving awareness, understanding, and day-to-day management of polymyalgia rheumatica, or PMR. We want to extend our gratitude to the CDC for supporting this important work. Now, PMR is a condition that can have a real impact on everyday life. In fact, many people experience pain, stiffness, and fatigue that make even simple activities like getting out of bed or getting dressed more difficult. At the same time, getting to a diagnosis isn't always quick or straightforward, and many patients go through a period of uncertainty before they have clear answers. In fact, even after diagnosis, there are still a lot of unanswered questions. What does this mean long term? How do you recognize a flare? What should you expect from treatment, especially when it comes to glucocorticoids? And that's exactly what we're here to talk about today. We'll walk through what a PMR diagnosis means and what comes next. We'll spend some time understanding flares and how to manage them, and then talk through treatment, focusing on steroids and tapering, and some of the concerns that often come up. But before we get started, we'd love to hear from you. Let us know where you're joining us from today. Feel free to drop your location in the chat box. In addition, just a quick note. This is meant to be an interactive session, so please feel free to send your questions at any time using the chat or QA box. We'll do our best to address as many questions as we can during this discussion. Our apologies in advance if we are not able to get to your question. With that, I'm really pleased to be joined today by two wonderful guests. We have Dr. Sebastian Sattui, Assistant Professor of Medicine and Director of the Vasculitis PMR Program at the University of Pittsburgh School of Medicine, who will help guide us through the clinical side of PMR. A very warm welcome to Dr. Sattui. We also have Mary Dunn, who will be sharing her personal experience living with PMR and what this journey looks like day to day. A warm welcome to Mary. Thank you both so much for being here, and let's dive right in. Let's start maybe with the basics, right? So, Dr. Sattui, for someone who's new to this, can you just explain maybe at the beginning what PMR really is?
Sure. Well, thank you again for the invitation. Thank you again for the opportunity to discuss more on PMR, which certainly needs further discussion. So again, congratulations for all the work. So PMR or polymyalgia rheumatica, which I'm going to keep referring to as PMR, is although really striking to everyone who hears about it for the first time, it is one of the most common inflammatory conditions that happen later in life. So as a matter of fact, in people over the age of 50, it's probably the second most common condition after rheumatoid arthritis. It is a disease that it's characterized, as its name says, as poly, which is many, and myalgia, that it describes, although in a very simplistic way, this kind of muscle pain that a lot of patients experience, and rheumatica that comes from an inflammatory condition. But it's an inflammatory condition that is usually presenting in a kind of acute or subacute onset that is primarily characterized by this pretty significant pain and stiffness that involves the structures outside of the shoulders and the hips, and then ends up also causing some involvement of the joint itself. But it's really characterized by this acute pain, stiffness that is usually described as predominantly in the morning, lasting for over 30 minutes, but that then ends up translating into a significant physical function impairment in patients, as you already mentioned. People who have experienced PMR know that goes just beyond the pain and stiffness, and that really impacts a lot of daily activities and that someone's ability to interact not only physically but also socially. So usually, again, it's this symptoms that present and who they present, and that blood work wise are accompanied by this what we call inflammation. So this inflammatory markers that are elevated, and this is the part where the diagnosis is not certainly done just based on one, but it's a conjunction of both clinical symptoms, laboratory work, and as importantly, also trying to do a full assessment of the patient to rule out what we tend to call potential mimickers. So conditions that can look or present like PMR, but are certainly not necessarily PMR. And that brings a lot of the challenges around the diagnosis because, as much as, and this is something that a professor of mine always told me, we would think that people and their bodies read textbooks, and they do not. Not everyone presents with a kind of classical presentation, and the diagnosis can be very challenging because, unlike in other conditions, and certainly this is true for a lot of rheumatic conditions that can, we do not have a test that says yes or no. A lot of the issues that come with the diagnosis of PMR and someone's journey with PMR is the presentation that cannot be fully typical and the lack of any specific testing for the disease.
Wonderful. So a lot of important information there. About the persistent pain in your shoulders, your hips, the symptoms that go beyond the pain and how they impact everyday life. And you touched upon the challenges since there's no one definitive test, which I'd like to come back to later. But I want to come to you, Mary, based on what Dr. Sattui said. Now, that's the clinical perspective. We'd love to hear from your perspective. Can you share a little bit about what it felt like when you were first diagnosed? Did you have a lot of different feelings? I assume relief, overwhelm, but also sort of, oh God, this all makes sense. So, what was that journey to diagnosis really like? Can you talk a little bit about that?
Sure. I'm very lucky to have really good insurance and a really good internist as my primary care doctor. And so when I went to my appointment to see someone about this body pain that I was having in my thighs and in my arms especially, but in other places too, and the terrible fatigue, um, he diagnosed me that day, basically. He said, "I think you have PMR." So we did blood tests and they came back as elevated. Inflammatory markers were elevated. When they told me, I had no idea what it was. I had never heard of it. I didn't know anyone who had it. And so I had to do some reading once I got the name of it and try to figure out what was going on. It felt very uncertain. It felt like now I have a chronic illness. I don't know anything about it. How long is it going to last? Will it be forever? Will I ever feel normal again? All of those questions came up for me.
So it sounds like there's a lot of moving pieces here,
Oh,
Mary.
definitely.
Yes, and I'm just wondering for those listening, just to give a sense of people who are maybe still trying to get diagnosed, from the time that you started experiencing symptoms to the time of diagnosis. Do you remember how long that was, and how long have you been living now with PMR?
It was a month up between the actual firm diagnosis and the initial visit. I started in May of 2025. On May 30th, I started having pain in my thighs and my biceps, my upper arms. And I saw the internist and he thought it was my statin drug. I take a statin for high cholesterol. So he reduced my statin by a few milligrams, a half of the dose. And I came back in 2 weeks to see if it had helped, and it hadn't. And so that's when we started looking further. So it really is a tortuous path. You have to wander around doing all kinds of looking and feeling to see what is actually going on. I keep track of my body and keep notes about how I feel so that I know how I'm doing that day. Now, one thing that I have to say is fatigue. Oh my gosh, that is awful. The fatigue, you get up, you try to do something and you can't finish it. You have to sit back down. That's been terrible for me.
I'm sorry that you, like many others, have been going through so many different symptoms, and it was such a challenge also to get the diagnosis, etc. Which brings me back to you, Dr. Sattui. Listening to Mary, we hear that her doctors initially thought it was to do with the statins. What are some of the biggest challenges you see when it comes to diagnosing PMR? from a clinician point of view.
Yeah, no, absolutely. And I think Mary's story, and thank you so much for sharing that, really exemplifies a lot of the issues around it, right? Whether that concern of now I have a chronic disease. There's this also bigger bad thing of GCA in the background that I need to be concerned about, which you always need to be on the lookout for. And then again, yes, well, I had the symptoms that could sound like PMR, but they could sound like a lot of other things. Another sometimes difficult challenge is there is sometimes a concern or expectation that later in life we're all going to hurt. And that is something that somehow needs to be accepted, but not if it's something such acute that leads to a complete whole different layer of changes, right? So as Mary, I think, was also saying, is that, well, I had this pain, but this was a pain that was difficult in my daily activities, was causing all fatigue going on. So there are symptoms, there's some degree of joint issues that we're all going to have, but it's the big picture, not necessarily just honing on one specific, but the whole impact on someone that really needs to be encountered. And I think that's another challenge. And a third challenge that comes to it as well, and I think it seems that Mary was lucky that she had a fantastic internist that recognized this on time, but this might not be the case for a lot of general practitioners or non-specialty providers that have not really encountered PMR. Maybe at some point in the book in their training, and even more so having access to a specialist in 2 weeks, where we know that is also very challenging as well. So there's different layers within the clinical challenges of the diagnosis, but also the access to care piece as well, that really make the complexity of diagnosing PMR.
Very well said. Yeah. And it really sort of brings the entire picture together, hearing from Mary's perspective and hearing from your perspective, the challenges that both clinicians and patients face. I want to come to something that both of you mentioned before earlier when we were talking, and that is the topic of flares, something that is very important both to the physician as well as, of course, to the patient. And Mary, maybe I can start off with you. Can you talk briefly about what helps you the most during a time when you are flaring?
I recently started flaring, and I couldn't exactly pinpoint why. So I went to see the rheumatologist again as a regular visit, and she suggested that I take a biologic injectable every week instead of every 2 weeks. And unfortunately, that didn't help. In fact, it really made me feel worse. So I stopped while waiting for a steroid shot from the doctor's office. And that's what I got that day when I went to see her. And she didn't seem concerned about it. She kind of told me to expect that sort of thing. And so I dealt with it that way. And I feel better since having the steroid shot. But, I can't live on steroid shots. I mean, they change your body so much, your hormones, your adrenal glands. And of course, they have some side effects that are very concerning, like osteoporosis. So I hope I won't have to depend on them in the future.
Yes, absolutely. And we hope so too. And Dr. Sattui, that is a very good point that Mary brings up, is this concern that people living with inflammatory conditions like PMR often ask is, on the one hand, steroids help greatly in clamping down the inflammation and the symptoms. On the other hand, we're constantly worried about the long-term effects of steroids as well as the short-term. So what are some of the things that patients can do at home if they're experiencing a flare? And how do you clinically define what a flare is? And is there such a thing as a clinical definition for a flare?
Perfect. I'll tackle the second question because it's easier to address, given that there's actually not a really agreed on definition yet. So the challenge with that, if you look into a lot of the PMR research, is there's a lot of focus right now on trying to understand like a unified definition, right? I think that's something that it's been a little bit further back. Usually, historically, what a relapse or a flare of PMR has been discussed on, or defined as, is a return of symptoms consistent with PMR. Which one thing that is important to say is that even though, again, PMR symptoms are usually thought as the shoulder pain and the hip pain and the stiffness, not everyone needs to, it's not that you get a set menu that happens every single time you relapse. I think that's one important point. So those symptoms that are accompanied with, in most cases, but not all, a change in inflammatory markers. And that's the usual definition. To me, a very important component of this is that physical, that impairment in daily activities. So I think it's very important for me when someone comes and tells me, well, maybe I'm having some pain, but it's bad. But no, I'm having some pain that today I could not, put on a shirt. Today I really had to wake up. I knew that I was not feeling good enough that I had to wake up an hour before I usually wake up because I had to plan stiffness into my day. So that like those symptoms plus the component of the physical impairment, that is to me very important into assessing kind of what the flare or relapse is, and also as important is actually assessing the impact on whoever is experiencing this. So that to me is crucial, and that's something that again needs a bit more refined on the more clinical researchy side of things, or at least a straight definition that can be used throughout. But that's what I usually assess in clinic. What drives a relapse or a flare is sometimes also very difficult. I don't think anyone can tell you that there's a one driver, because if we have, our bodies are complex, and certainly these diseases are as well. But sometimes relapses can happen in the context of tapering of the prednisone. Infections are something that we know can lead to relapses of disease as well, because our immune system gets activated. And that can happen in PMRs, we know, with many other diseases. Again, we do not exist in compartments. So I've heard several times I've dealt with a stress, I had a loss in my family, and that also kind of really just lead to a relapse of disease, which again, a lot of things can happen, but it's really assessing the components of everything and communicating with your doctor. To me, is as important, because as much as as physicians, we have all the medical knowledge about this, I usually tell every single patient, nobody knows your body better than you do. So this is where the communication comes into play, and it's just assessing all those components into it. What usually comes after the relapses in most scenarios is, yes, increasing the steroids in most situations, and to really kind of address the symptoms, get back to the situation where symptoms are controlled, to then try to start going down again.
Great. I think, one of the really important things you said is, you know your body best. And so to keep aware and maybe even keep track of your symptoms, using either an app or a journal so that you can communicate better with your doctor. We're going to pause for a moment for a quick community poll. You should see a link in the chat. In addition, a QR code will appear on your screen. You can click either. Participation is completely optional, but it really helps us to understand your experiences if you participate. So our request is for you to participate. We'll also share a summary of the results afterwards if you join our mailing list. We hope to see many of you join the mailing list and stay in touch with you and engage with you so we can learn better about this condition and your experiences. I want to move now into the management of PMR, starting with glucocorticoids or steroids. And we've already talked a little bit about flares, about managing the disease, about this sort of a love-hate relationship that people have with steroids. Dr. Sattui, coming to you first, how do you approach creating a tapering plan? Because you want to support patients who are concerned, obviously, about side effects, and also patients who want to taper too quickly. So what is the balancing line? How do you do that?
So the first thing first is you need to know your patient, and you need to understand where we all know, sadly, rheumatologists know quite well of all the side effects and the concerns or potential adverse events related to steroids. So you need to have a full medical history to really understand what are the components, if the patient has diabetes, if the patient has osteoporosis, to understand where you're starting, because unfortunately for some people, the steroid problem issues start a little bit ahead of the race. I think the whole concept about this tapering scheme, not to getting too much into the weeds of this, but like needs to be revisited, because what we constantly get reminded in a lot of our diseases is there's not a one size fits all, right? And I think this tapering regimen that has been proposed, it really needs to be revisited, because if anything, what's the most recent studies show that in some people, a shorter taper can really be used. This is, of course, with a patient understanding that relapses can happen in 43% of the patients, but if you can really achieve those lower doses earlier, that is something very important as well. Uh, of course, the concern about the side effects needs to be revisited, and patients need to be educated on two very important things at the beginning of their treatment. One is that every single patient needs to be aware of GCA, and this is something that every single patient needs to be educated on since their very first visit. And the second visit is understanding again what are potential side effects from steroids and how this can be monitored.
Wonderful. And when do you consider, just very quickly, if you consider at all, adding other medications to steroids?
We have the fortune that we get to talk about this nowadays, which is fantastic. I think we need more data on this, and that's my I guess my way of escaping a direct answer to this. But like I said initially, if I have someone who I know has very difficult insulin dependent diabetes, who already has osteoporosis, this is a conversation that I have with a patient earlier on, saying I do have these concerns. You know, every single medication has side effects. Unfortunately, we know that the coin is weighted for having something with steroids, especially if they already have some kind of comorbidity. And we discuss about the evidence behind the steroid-sparing medications, which if you use them, the goal is to spare steroids. So that's where you really need to do a faster taper because, again, that's a big goal. It's getting the disease under control and getting your patient off of steroids. Later down the road, I think we need a little more data, but I usually use the 6-month cutoff and someone is already start remaining on 5 or 7.5 or above, because that tells me a little bit of what can I expect longer run, and really emphasizes this. And I think that's, again, a change that needs to happen now that we have effective steroid-sparing medications. But that also comes with getting people to specialty care faster, because our internist colleagues are fantastic, but they are not used to using these medications. And creating better models of shared care, of better communication between specialty and non-specialty is crucial to identify those patients and actually be able to use these fantastic tools that we're fortunate now to start having.
Wonderful. What a fantastically optimistic and hopeful note to bring this section back to Mary. The fact that we have these steroid sparing agents. Mary, from your experiences, you talked earlier about being on steroids. What were some of the most challenging side effects and what really helped you manage them to the best?
Well, remember that I was on a very low dose of steroids. I started off at 15 and that was the highest dose I was ever on. So I'd never got the stomach irritation that can happen if you're taking steroids. In fact, it's recommended that you use an antacid along with your steroid tablets every day. But I didn't have an issue with that. So I did okay there. Interestingly, people who I communicate with online through support groups, they're labeled polymyalgia rheumatica on Facebook, and I found two that I really like. They talk about being dependent on steroids. So there's this idea that somehow you can't get off them, and you have to suffer through some kind of withdrawal to get off them. That isn't necessarily the case, but it's a fear-driven belief that somehow you're not going to be able to get off. And that's scary for people.
Absolutely. All this information is so helpful to those who are listening in. And in fact, we've got so many questions. And I just want to thank both of you for all your insight and information, sharing your experiences. But I want to allow for a little time to also ask questions that are coming in at breakneck speed here from those listening in. So maybe we can do 2 or 3 questions before we unfortunately wrap up the session. I really wish we could do a part 2 and a part 3 because there's so much information here to learn from. So let's see. I'm trying to condense these questions as best as I can. Why don't we start with you, Dr. Sattui? A lot of patients, and I suppose the same question will come back to you, Mary. A lot of patients feel like their appointments are very short, right? Too short sometimes to cover everything. What, in your opinion, is the best way to advocate for yourself, to ask the right questions so that you can make the most of your appointments and to make sure your doctor is really hearing your concerns? So Dr. Sattui, from the perspective of the clinician, what would you say?
Wonderful. Yeah, no, I think that's great, and that reality is something that I'll just voice as I guess the clinician on this talk is it is frustrating. It's as frustrating for patients as it is for us clinicians. Uh, what I usually tell patients is that for clinic myself when I go as a patient as well, I apply the same rule as when I have a work meeting. I plan ahead. I have a list of questions. I love when patients bring a list of what things they want to talk about just and they go through the checklist and make sure because that is a good way to make sure that you really are going to address all your concerns. I think sometimes patients also send their like heads up, like a message again, like the same way as I send an agenda to someone before a meeting, and that's a way that again you have your list of important things for you that you want to discuss, and sure something might pop up in the conversation, but that preparation, like pre-appointment, pre-meeting, to me is very important. I think trying to really keep that conversation going. I always tell patients that by Murphy's Law, they might be in the clinic and they forget about one question. Once they walk back, send us a message because I think keeping that communication, trying to address those concerns is just very important. But I think trying to optimize time, trying to have that list, trying to remind your physician what is important to you, that is what matters to me, and that's how I know that besides whatever I prescribe or whatever blood test I send, I'm helping patients. I'm doing my job.
Wonderful. So well said. Mary, would you like to add something to that?
I think it's very important to make your list of questions before you go and to be able to express exactly how you feel to the physician. Luckily, my physician believes me when I tell her I feel terrible, and she will offer me alternatives. So I feel very lucky. And another thing she does is she has me complete a activities of daily living questionnaire so that she knows exactly what my limitations are.
Wonderful. And I keep hearing this communication with your clinician and keeping track of your own body, your own symptoms is really important. One of the other questions that has come in from many people actually are about lifestyle behaviors. So, do we know if there's any research that supports a specific diet or exercise that can lead to better outcomes or help manage PMR better? Dr. Sattui?
Sure. So I will add an extra layer to this because it's something that you really talked about, which is very important. It's the use of patient-reported outcomes. So we know that very strictly what we look and we consider what is the disease, right? And the measures and the CRP that goes up, down, left, right. But we now a lot of research is showing how even despite disease being adequately controlled based on our metrics, patients continue to present physical function impairment and fatigue. And this is not necessarily captured by the traditional metrics, but it's captured more by patient-reported outcomes, like what is available on apps, and that is very important. I think that implementing that in the future, that is where we are not going to be able to just treat our patients better, but also find better treatments, like what I think patients are asking and alluding about. To my knowledge, there is as of right now, nothing specifically with regards to diet. I think there has been a lot of interest with regards to anti-inflammatory diet, and there's probably some data that's starting to pop up in the context of rheumatoid arthritis. So I think what I usually tell patients is certainly a healthy diet is very important, as anyone would. We know that we are what we eat, and that is very important overall for overall health, and that has its role as well in the management of autoimmune or inflammatory conditions. I think physical activity is something that we should and must do better in the treatment that goes beyond just the prescription of steroids. I think we need to better understand how we can keep physical function, how we can keep movement, how we can prevent the muscle loss that happens with age, but also accelerated by steroids that we know quite well. And that kind of really has an impact in life. So there's been very few studies looking into this, mostly just patients reporting what they do and what has worked for them. But I think there's a need to really adapt and do an actual intervention, and not only like what is the best kind of exercise, but also when to start it. Because the truth is that probably earlier is the better. Naturally, a lot of patients feel like, oh, I just had PMR, I just started treatment, and I'm on the steroid, I'm not gonna do it. But we know that motion is lotion, and that is very important for any kind of joint or autoimmune disease, but even more so for PMR, where stiffness and lack of activity has really impacted people, especially with delays of treatment. So that is something that I think is in the pipeline from some researchers, and hopefully will be incorporated more soon.
Great point. Thank you. And it's sort of counterintuitive because you might be in pain and you might be very stiff, but if you move, you might start to feel a little less stiff and experience a little less pain. Mary, I think we have time for one more question. And I want to ask both of you this. Sometimes you're on treatment, and sometimes your biomarkers look good and you're still not feeling good, right? You might be experiencing pain despite treatment, despite the steroids, etc. Mary, have you gone through that? And in that situation, what have you done? And then I'll come back to Dr. Sattui to ask him for his clinical opinion as well.
When I was using the injectable biologic, it really changed my levels of inflammatory markers in my blood so that I never seemed to have a problem according to those lab tests. But I still felt bad and I still had chills and fever. I talked to my doctor about it and she expressed concern, but recommended that I use some kind of, not NSAID pain relief, but acetamin for pain. And there's a timed release capsule for pain that is acetamin for arthritis. That's very good. It lasts for 12 hours. And so I use that.
Wonderful. Thank you, Mary. And, at Global Healthy Living Foundation, we always say, please speak to your doctors first before you start any medication or make any changes to your treatments or medications. But Dr. Sattui, this often comes up is that patients are on treatment or their blood markers, biomarkers are looking good and still they're not feeling good. What is the reason for this? Do we have any insight on that?
So that's why I was trying to talk about some of the patient-reported outcome data, right? Because it really allows you to understand all the different layers. This is not just like a disease, again, that affects the shoulders and makes the CRP go a little bit up. There's impacts on physical function, there's impacts on fatigue and pain, even in sleep, and there's more and more studies that are coming. And this is not a novel kind of concept because it has been very well described in other conditions as well. So I think there's a need, again, to better understand what are the dimensions, what is really driving a lot of these changes, and what other interventions that might be truly related to active disease or not, or what other interventions can be done that really help in the management of the symptoms. So I think there's still some layers that need to be kind of uncovered there to better deliver care. I think one point that is very important to what Mary said is that it is true, and again, I said this definition of relapse, that the inflammatory markers symptoms usually accompanied by increased inflammatory markers, but there's a minority of patients where we know that inflammatory markers might not change. So again, this is why relapses are diagnosed clinically as well. We do not treat blood tests, we treat people. So it's something that we need to really take into account, and again, do a full assessment, because this is a complex disease, and we need to treat the patient as a whole, independent of one just marker itself.
Absolutely. Thank you so much. Unfortunately, we're coming up on time here. And before we wrap up, I just wanted to sort of bring together a few of the takeaways that I heard from today's discussion. First, of course, is that PMR can be disruptive, but it is manageable. And when the treatment is right, and with the right kind of support, people are able to feel better and get back to their daily routines. The second is that diagnosis can take time, as we've heard both from Mary and Dr. Sattui, and that's something many patients experience. But once PMR is identified, starting treatment early can really make a difference. We also talked about flares. These are a normal part of the condition, unfortunately, but learning your own patterns and early warning signs can really help to manage them more effectively. Listen to your body was heard repeatedly, loud and clear. And when it comes to treatment, especially steroids, they can be very effective, but it's important that you speak to your doctor about tapering schedules. Long-term decisions are personalized and guided by you and your healthcare provider. And finally, and I think most importantly, staying connected, right, to your care team and to the trusted resources is really key, because you don't have to manage this condition by yourself. Dr. Sattui and Mary, thank you so much for joining us today on this important discussion and giving us such important information and sharing your own experiences. Before we wrap up, I want to mention that we have a dedicated PMR website with printer-friendly resources, education material, and support on living with PMR. You can see the URL on your screen, and we will also put it in the chat and the webinar description for the video. To access this website, visit ghlf.org/live-PMR. I encourage you to explore it and sign up for updates so you can stay connected with us. Thank you once again so much for joining us, and big thank you to the audience as well for participating with us. We hope to stay in touch. We apologize for the questions we were not able to answer, and we hope we can get back to you either through an article or through a part 2 of something like this. Thank you again, and have a good day.